Today we have two speakers. We have Dr. Jane Chung, who's one of our sports medicine physicians here at Scottish Rite. Dr. Chung has a particular interest in today's topic. She's spoken both locally and nationally on it, and we're really looking forward to this topic. She's joining today with Taylor Morrison, who's a licensed dietitian. She also has she's board certified in sports dietetics and works alongside our sports medicine team to provide nutritional guidance to our young athletes. They're going to talk to us a little bit today about optimizing nutrition, bone health, and performance in our young athletes. Should be a great topic, and really looking forward to it. I'll turn this over to Dr. Chung.
All right. Good morning, everybody. Thanks for joining us this morning. We're going to go over our objectives. So we will discuss the components of male and female athlete triad and relative energy deficiency in sport using current nomenclature to address the spectrums of each component. We'll also talk about the relationship between underfueling and injury risk, including bone stress injury. And lastly, we'll discuss screening and prevention principles for bone health, reproductive health, and nutrition for young athletes. So we all know that there are many benefits to participation in sports in our youth athletes. Aside from the physical benefits, there are the mental benefits, the cognitive benefits, and also importance of learning life skills such as teamwork, building leadership skills, building confidence, and self-discipline. In 1972, the government passed Title IX, which is the Education Assistance Act, and that stated equal opportunity for women's and men's program activity that receives federal assistance, including sports. And this really paved the way to an escalation in female sports participation, especially at the collegiate level. So males and females have anatomic and physiologic differences. Some of them are listed here. Females have less lean muscle mass compared to their male counterparts. They also consume more oxygen with weight-bearing exercise, and males have larger total cross-sectional areas of muscle compared to females. Some other anatomic and physiologic differences: females tend to have a smaller heart rate, lower blood volume compared to males, smaller thorax and lungs, and also a lower VO2 max. So now we're going to talk about 4 athletes that Taylor and I have both seen in clinic or are currently treating together. So we'll introduce 2 females and 2 males, and we'll take them along the ride with us over the next hour or so in our talk. And these are real patients. We have created fictional names for them. And so our first female athlete is Taylor. So Taylor's a senior lacrosse athlete. She's already got a full ride, and she's committed to play at a D1 college next year. So she showed up to sports medicine clinic for about a month history of atraumatic right foot pain. That seems to be getting worse. It was initially activity related, but now it's nagging her all the time, even with walking and simple activities of daily living. She denies any history of stress fracture or bone stress injuries, and some initial history that we were able to obtain. She started menarche at age 13, and she said, "Oh yeah, by the way, I have this history of vitamin D deficiency a few years ago that I took some vitamin D supplements for." So on clinical exam, I was very concerned about a stress fracture in her foot, and an MRI was subsequently obtained, which did show that she had 3 stress reactions in her foot, including the navicular bone. We rechecked her vitamin D level, which was strong and healthy at 62. And then when I called mom to talk about her MRI results and plan, patient chimed in and said, "Oh yeah, I also have a history of skipping my cycles. I usually skip 2 to 3 times a year, and it's mostly when I'm in season training a lot."
I'm going to introduce our second female athlete we're going to talk about this morning, and that is Jane. She is our 13 plus 8-year-old female. She's premenarchal, so she's not yet started her menstrual cycle, and she is involved in multiple sports, so probably about 5 or more sports throughout the course of the year, not really having any off season. She was referred to us by her pediatrician specifically to be evaluated for the female athlete triad. When she came to us, she had experienced an increase in exercise over about the last 3 months. We actually discovered that there was some secretive exercise going on, exercising alone in her bedroom without her family or her parents knowing. She was also starting to exhibit some restrictive eating behaviors, like not wanting the rice or the pasta or bread at dinner. We kind of talked about that, and she was saying, yeah, I'm trying to cut back on my carbohydrates. We noted that she had lost 10 pounds in 1 month, falling from her natural curve on her growth chart. Her pediatrician had drawn some labs, and there was a large panel of labs that we received, but we wanted to call out these labs for this morning. Her vitamin D was 31, which is not super low, but we definitely like to see that higher in our young athletes. Her T3 was low at 1.8. Her TSH and T4 were drawn and were normal. Her BUN, 29, mildly elevated, showing a little bit of dehydration. And then due to her low heart rate, her low blood pressure, her pediatrician actually referred her to a cardiologist. And there an EKG was performed, and the cardiologist read that as sinus bradycardia. So when she came to us at our initial visit, we of course did vitals as well, found that our heart rate was 51, which is lower but up from the 46 that it was at her pediatrician visit about a month and a half ago. Her blood pressure was 100/55. Her BMI was in the 18th percentile, and her weight was in the 23rd percentile, which, if you look at those data points individually, seem completely fine and normal, but we're always looking at trends when it comes to a growth chart, and we can see that her natural curve is at the 50th percentile, and today she had dropped to the 18th and the 23rd, so that's that's concerning for us. She also completed our female athlete triad questionnaire, and we had 2 yes responses. One being that yes, she worries about her weight, and the second one that yes, she follows a special diet. She said specifically that she tries to avoid carbohydrates and decrease sugar.
So our 2 male athletes that we'll now introduce. So Shane is a 17+1-year-old male gymnast. He trains about 22 hours a week. And he came to sports medicine clinic saying, hey, I've been having this nagging right shoulder pain and collarbone pain that's been going about for a month and a half. And it's only when I'm doing upper extremity weight-bearing activities. So mostly like the P-bars, pommel, rings. He does have a history of a stress fracture in his low back last year, which he was treated and managed for. And so in clinic, there was a high suspicion and concern that something may be going on, like a stress reaction or stress injury to his collarbone, because he had significant tenderness in that area. And so an MRI was obtained, and it did show that he had a right proximal clavicle stress reaction. Because of his recurrent bone stress injuries, he's had now 2 stress fractures in the past year. We did order some bone health labs, and nutrition was consulted to evaluate for possible concern for underfueling in this high-level gymnast who was training 22 hours a week. Of note, his vitals were stable on initial presentation. His weight was in the 65th percentile, his BMI was in the 75th percentile, and his height was in the 50th percentile. Now we have our next male athlete, Jacob, who is a 15+4-year-old 9th grade cross-country runner, and he was running about 25 miles a week. And the reason he came to us to see us in sports medicine clinic was for further care for his stress fracture. So he was just recently diagnosed with a right proximal tibial stress fracture by his Arasti group that he had been seeing for a few weeks, and so they wanted to have further management and care for his stress fracture. However, when we saw him in clinic, he was also complaining of pain in both of his knees that were intermittent, kind of waxing and waning. His history for why his right shin started to hurt began in May after returning back to running after a prolonged period of rest. And he was resting because he was also diagnosed with an eating disorder, anorexia, about a year ago. And so he was in intense inpatient treatment and is currently still being followed by a eating disordered specialist on a weekly basis. And so he kind of suddenly ramped back up and went back into running after this prolonged period of rest while they tried to optimize his nutrition for his anorexia. So he initially came to us with some recent blood work that his pediatrician had drawn, and most notably his ferritin level, which is your body's iron store, was extremely low. So it was at 6. And he actually was being followed by a hematologist for this and was also receiving iron infusion for this as well. His vitamin D level was suboptimal. His electrolytes were normal. He did have some signs of mild dehydration from elevated BUN and creatinine levels. Also noticeable was his absolute lymphocyte count was on the lower end, okay? And so that's your body's immune system and immune response. So on initial exam, because he had a lot of knee pain and also thigh pain, I ordered some further imaging, and lo and behold, the MRI showed that he had some additional stress fractures and stress injuries to his body, where it was found he had bilateral distal femur stress fractures, along with a new left proximal tibial stress reaction, in addition to the current right proximal tibial stress fracture that he's currently being treated for. So now that we've introduced our 4 athletes, we'll talk about how each of these fit into the triad, okay? So we'll start off with the components of the female athlete triad. So the 3 components include low energy availability, impaired bone health, and menstrual dysfunction. Each component lies in a spectrum, and the underlying root cause of these is low energy availability or underfueling. And the triad occurs when energy intake does not adequately compensate for all the exercise and the energy that's expended in a high training athlete. So the American College of Sports Medicine first described the female athlete triad back in 1997. And the initial definition was an athlete has to have osteoporosis, a diagnosed eating disorder, and amenorrhea. Well, since then, the definition has evolved, and now we know that the female athlete triad components lie in a spectrum. And so this was published by the Female Athlete Triad Coalition Consensus Statement, and you can see on the far right, there's the green triangle, where a healthy female athlete has optimal energy availability, optimal bone health, and have normal menstrual cycles. And then there's this big spectrum in which any of the athletes can fall in any of the spectrum at this point. And on the far left end, you have the red triangle, and those are the athletes with the most severe case of female athlete triad, where they do have osteoporosis, functional hypothalamic amenorrhea, and low energy availability with or without a disordered eating. And it's important to note that athletes can have 1, 2, or all 3 components of the triad. So how does this fit in with Taylor? Okay, so Taylor, remember, is our senior lacrosse athlete who's got a full ride going to play lacrosse at a D1 school next year. So she came in and presented, and we found that she had impaired bone health, right? So her MRI of her foot showed that she had stress reactions in multiple bones in her foot. Upon further questioning with female athlete triad questions, we also found that she had irregular menstrual cycles, right? So she said she would skip her cycles 2 to 3 times a year, mostly when she was in season. And so because she had these 2 components, we were concerned about energy deficiency or low energy availability. And so further evaluation looking at that was obtained for her.
Now we look at Jane and see how the components of the female athlete triad apply to Jane. So as I'm assessing and chatting with her, I see that, she has that low heart rate, she has a lower blood pressure. I really am drawn to this 10-pound weight loss in the last month, and the fact that she's falling from her natural curve on her growth chart, and the fact that she worries about her weight. These are all red flags to me that she's exhibiting and experiencing energy deficiency. These are all big signs of energy deficiency or low energy availability. And because of this, we know we want to look and talk to her further to assess for any risks in impairment in her bone health, as well as potential menstrual dysfunction moving forward.
Talk about the components of the male athlete triad. So the male athlete triad was initially defined in 2021, where they released the Male Athlete Triad Coalition Consensus Statement. And it's important to note that the male athlete triad parallels the female athlete triad. And so researchers started to note that, hey, there's something similar that seems to be going on in our male athletes that is similar to those who have female athlete triad in terms of similar adverse health consequences. And so this was mostly seen in our male athletes who had participated in sports that emphasized leanness, aesthetics, and endurance, such as the male cross-country runners and gymnasts. And so the components of the male athlete triad include low energy deficiency or low energy availability, similar to the female athlete triad, and this is the main underlying root cause of the male athlete triad, as seen with the female athlete triad. Impaired bone health is the next component, and then reproductive suppression. So obviously males don't have menstrual cycles, but there we're seeing the negative consequences in reproductive suppression in male athletes. So this is a very similar diagram that we just showed, similar to the female athlete triad, and we know that the components in the male athlete triad also lie in a spectrum, from healthy all the way at the far right end with the green triangle to any subclinical presentation they may have in between, to the most severe form of the male athlete triad in the red triangle at the far left end. So let's talk about Shane again. So how did his presentation fit into the male athlete triad? So remember, Shane is our level 10 gymnast who trains 22 hours a week, and he was diagnosed with a proximal right clavicle stress reaction. So remember, he also had a history of stress fracture in his low back last year, and so he presented with impaired bone health. And because of his reoccurring stress fractures, we did obtain bone health labs, and there was concern for underfueling because of his high volume of training, high volume of sport participation. So I was concerned about underfueling, and a nutrition consultation was placed for further evaluation for this. Moving on to Jacob. So remember, Jacob is our 9th grade cross-country runner who was diagnosed with anorexia about a year ago. So right off the bat, he came in with energy deficiency with an actual eating disorder diagnosis. And he also came in with a diagnosis of a right proximal tibial stress fracture that an MRI was obtained from externally. And then in clinic, we also obtained further imaging, which showed that he had 3 additional stress injuries to his bone in his femurs and in his left tibia. So he's got these 2 glaring components of the triad. He also had a DEXA scan looking at his bone mineral density that was obtained externally after he was diagnosed with anorexia, and it showed that he was at high risk for low bone mineral density for his chronologic age. And so further evaluation was done, and there was really high concern for components of the male athlete triad and Jacob. And so you can see that athletes don't present with all components at the same time. But because our athletes had one or more of the components at their initial visit, and based on our history, clinical concern, and clinical judgment, further evaluation and workup was done to evaluate for other components of the triad. And so you can see that presentation can vary, and they don't always present with all components at initial presentation. So moving on to some of the risk factors for the athlete triad. And so the athlete triad can occur in any sport, right? You saw our senior lacrosse player who had components of the athlete triad, but these are some of the sports that are at higher risk. And we know that those athletes who participate in sports that emphasize leanness, aesthetics, endurance, or weight class sport are at a much higher risk of having the athlete triad. So for instance, your high-level gymnasts, your cross-country athletes, your dancers, or your wrestlers, or your lightweight rowers like the coxswains, those athletes who start sports specialization at a very, very early age, or if there's a history of family dysfunction, abuse, or following diet fads or trends, those can also be risk factors to look out for as well.
Now that we've introduced our athletes, and we've talked a little bit about, what is the female athlete triad? What is the male athlete triad? We're going to take a little bit of time, and we're going to go deeper into each component. So we're going to talk a little bit more about, what is energy availability? We're going to talk about bone health. We're going to talk specifically this morning about the menstrual dysfunction. I'm going to start us out with talking about energy availability. What is energy availability? So kind of that textbook, very clinical term is the total energy intake at the end of the day, in the day, minus the energy expended from exercise divided by kilograms in fat-free mass. And you're going to get a number. So that's kind of the textbook definition. But what we really want to know just in the everyday, because I don't expect people to start going out and getting specific and measuring their athletes and doing this equation. What you really want to know is that overall energy availability is the energy left over kind of at the end of the day after you subtract everything used for exercise and sport to do the basic physiological functions of the athlete. So having normal hormone cycles, your heartbeat, breathing, all of those just daily functions. That is energy availability. And we know, like Dr. Chung said, it can exist on that spectrum of optimal to very low. And so when we're looking at what is optimal energy availability, we know that the actual number is this 45 calories per kilogram of fat-free mass a day. And that is the number where we find athletes are in good health, they're having great performance, and they're not having and experiencing these other complications that we've talked about so far. We know 45 is the goal, but a lot of times there are athletes that are trying to gain weight or build muscle, or they may be going through a growth spurt. They actually need a little bit more than that. And so as we go down, slide down that spectrum, we eventually get to low energy availability. And that is defined as less than 30 calories per kilogram fat-free mass. And that's where we start seeing these negative consequences in metabolism and reproductive health, bone health. That's where we start seeing these complications, injuries, and these signs and symptoms. I'm specifically looking at this when I'm talking about and assessing Jane, because I know she is exhibiting low energy availability. And so I can tell from assessing her, from her weight loss, that she's likely somewhere down in this 30 or less calorie per kilogram range. And we need to work on optimizing that. Also looking at reasons that the athlete may be experiencing low energy availability. And what I found in practicing is oftentimes it falls into two buckets. There's intentional underfueling and there's unintentional underfueling. And unintentional underfueling can be super common. The athletes, it usually occurs when an athlete has increased their training, whether that's length of time, mileage, intensity. Maybe they're starting to do an additional sport on top of something they're already doing. So their energy expenditure has gone up, but their intake has not gone up to match it, just because they're so busy or they're so active that they just don't have an increased appetite. And so there's this gap. And we can work with them to educate and to strategize and to increase their energy availability and get them well fueled again. But the other bucket is this intentional underfueling. And that can really occur in like a lot of our aesthetic athletes, weight-centric sports, when an athlete may be trying to alter their weight or their body composition for performance. Or it could be an athlete that decided they want to try a special diet that they saw a friend do or someone in the media do, and they wanted to follow it, and it involves cutting out foods or food groups, and then they get this gap and they start to experience that low energy availability. And that can take a little bit more time to educate and really work with them to optimize their energy availability. And in some cases, it's we discover that it's more serious, and there's actually an underlying clinical eating disorder going on. And so we refer out to the community. And so for our athlete, Jane, we worked with Jane for a while. I worked with her very closely, and we realized that her low energy availability was more due to intentional underfueling, and there was potential an eating disorder going on. So we did have to refer her to a clinician in the community.
So So menstrual dysfunction is the other component that we talked about in the female athlete triad. And so there's a spectrum of menstrual irregularity. So this is just to go over the definition so that everyone's on the same page. So eumenorrhea is having normal menstrual cycles, so optimally every 28 days plus or minus 7 days. Oligomenorrhea is when their menstrual cycles are more scattered apart. So cycles are every 35 days or longer. And then amenorrhea is having no menstrual cycles at all. So primary amenorrhea is when a female has not started menstrual cycles by the age of 15, but they do have other secondary sex characteristics. And secondary amenorrhea is in a female who has already started menarche. However, they have not had a cycle for more than 90 days consecutively. And this is what we frequently see in those athletes who have female athlete triad. They can present with months and months of no menstrual cycles, and that's what we call functional hypothalamic amenorrhea. It's important to note that when a female first starts their menstrual cycles, that it's normal to have irregular cycles for the first 1 to 2 years. So that's also important to keep in mind as well too. So what happens when we start having menstrual dysfunction? Like, what does the body do? So our body is very, very, very smart. And so when it senses that there is low energy availability or underfueling, it starts to shut down other processes to conserve as much energy as possible. So one thing that it does is it sends this negative input to the brain. And the brain, specifically the hypothalamus, starts this cascade where it starts inhibiting release of all these various hormones, like the gonadotropin releasing hormones, the LH, the FSH, and then it negatively affects the hormones that are produced by the ovaries, which gives us our cycles. And so it starts shutting down this process, and that's how you develop abnormal menstrual cycles in our athletes with female athlete triad. And so we call this functional hypothalamic amenorrhea, where they don't have cycles in an already normally cycling athlete for 3 months or longer. And so this is a diagnosis of exclusion. Obviously, you want to make sure that they're not pregnant, that there isn't any underlying anatomic or structural cause that might be causing them not to have their periods. But in a underfueling athlete with low energy availability, this is one of the things that happens. So why is it important to have normal menstrual cycles in a female athlete or in any female? So the estrogen that's produced, that's released in a menstrual period for the females is important for building strong bones. And so estrogen stimulates and promotes osteoblastic activity, which are the bone building cells. And so that's why it's super important that females do have normal regular cycles, because it positively affects good bone health. There's been some research that have shown that amenorrheic adolescent athletes have significantly lower bone mineral density compared to adolescent athletes who have normal cycles or normal periods or sedentary controls. And so, again, low estrogen contributes to low bone mineral density in amenorrheic athletes. Also, it's shown that looking at the lumbar bone mineral density and weight-bearing aspects of bone mineral density, that's all positively affected by estradiol, again, released when we have our cycles, and negatively by the duration of amenorrhea or the age of menarche. So the longer a female athlete is in the state of amenorrhea, or the later they start their menstrual cycles, like 16, 17, 18, the more negative impact it's going to have on their long-term bone mineral density and bone health. And obviously having low bone mineral density, we know, is a risk factor for developing osteoporosis, pathologic fractures, and things like that in adulthood. So this is just a quick slide. Taylor and I often hear this in our athletes, where they say, oh, most of my teammates lose their period when they're in, cross-country season, so it must be normal, and it's kind of nice, so that, I like to run without having my periods. Well, losing period while in season is not a normal response to training. And so this is likely a sign of low energy availability or underfueling, and it's important that we discuss with their coaches or athletic trainers or their medical provider and educate them that this is not a normal response. Many factors contribute to bone health in an individual. Genetics plays a huge role, unfortunately. However, there are other factors, extrinsic factors, that play an important role for one's bone mineral density and bone health, such as physical activity and exercise has positive effects. Lifestyles, smoking, alcohol, drugs, those can have negative effects. Also, nutrition plays an important role in one's bone health as well, too. So when we look at bone health, we know that there's a spectrum that these components lie in, as we talked about in the athlete triad. Low bone mineral density does increase the risk for stress fractures, and also these changes may be irreversible. So that's why it's super important that we catch these early, because if it's too late, these changes of low bone mineral density may be too late. Also, really important thing to keep in mind is up to 90% of peak bone mass is obtained by the end of adolescence. So in our females, that's by the age of 18, and in our males, it's by the age of 20. So think about it, 90% of your peak bone mass is gonna be built by the time you're 18 or 20. And so the kids, it's all the kids that we're seeing in our clinics, in our practices, right? So it's super important that we are well educated and that we intervene early when there is concern for poor bone health. This is just a quick definition. So the International Society for Caloric Densitometry says low bone mass for age is defined as a Z-score of less than -2. The American College of Sports Medicine, which is the definition that we use in sports medicine, defines low bone mass for age as bone mineral density or a bone mineral content Z-score from -1 to -1.9. Along with clinical risk factors in those athletes who are engaged in weight-bearing sports. So clinical risk factors includes history of stress fractures, hormonal deficiencies, nutritional deficiencies. So who should get a DEXA scan? So DEXA scan is the test used to evaluate an athlete's bone health or bone mineral density. So that's the standard testing that's done currently. And the Female Athlete Triad Coalition has put out some guidelines of which athletes should we be getting DEXA scans for. So I'm not going to go through all of these, but you can see that if an athlete has one or more high risk factors, then they should be getting a DEXA scan. Also, if they have 2 or more moderate risk factors, then there should be strong consideration for obtaining a DEXA scan as well too. So looking specifically at our patient Jacob, so this is our cross-country runner who was diagnosed with anorexia and has multiple stress fractures that we're treating for. I starred the components that he had. So he had multiple high-risk factors. So he has a history of a eating disorder, DSM-5 eating disorder diagnosis. He also has had multiple stress reactions and stress fractures currently, and then his prior bone mineral density score was very low for his age. And so he's got multiple factors. And so if an athlete has low bone mineral density, then we do repeat it. I usually wait about a year to see if there are any positive changes, just because these changes can take a very long time for us to see the results. And so we'll probably recheck in about a year or so for him. Bone health and sports participation. So athletes who participate in weight-bearing sports have about 10% greater bone mass than their non-athletes. And so we see a lot of gymnasts, we see a lot of runners, endurance athletes, soccer players, basketball players. So those kids should technically have a much higher bone mineral density compared to their non-athletic counterparts. And so if you've got a high-level training athlete whose bone mineral density is not optimal, then that's already kind of a red flag right in that area. Adam Tenford and Michael Fredrickson have published a study looking at the influence of sport participation in bone health in young athletes. And what they found that was really interesting is that those athletes who participate in high and multi-directional impact loading activities have the most positive effect on bone density and bone geometry, especially in those anatomic locations that are directly being loaded by that sport. So for instance, gymnasts, they're loading their lower extremities and their upper extremities. It's a high impact loading sport, and so it's shown that those athletes have a higher bone mineral density. Volleyball, karate, and other jumping sports also are considered high loading and high impact sports. And then their study also showed that those athletes who participate in multi-directional sports like soccer, basketball, racket sports like tennis, lacrosse, and speed skating, that directional impact also has a positive effect on an athlete's bone mineral density. There's been some inconsistent data looking at participation of distance endurance running, if it has any positive improvement in bone mineral density, and the results have been a little inconsistent. So in 2014, the International Olympic Committee introduced this idea of relative energy deficiency in sport. And so this is an expanded concept of the female athlete triad. And so they propose that, hey, there's something far more beyond the female athlete triad with low energy availability. And so Taylor's going to talk about what that is.
This is a great graphic to help show you all that relative energy deficiency in sport, or we can call it red S, all that it can impact in an athlete. And so this shows how red S and the triad go together. The triad is kind of a part of red S, but this is basically showing how low energy availability can impact multiple systems in the body and affect an athlete in multiple ways. And so we've just starred the systems or the circles that our athletes had affected. So, there was some menstrual dysfunction, endocrine dysfunction, hematological concerns, physiological concerns, psychological with anxiety or depression. We had some cardiovascular concerns. This just shows that low energy availability has this greater impact on our athletes' health and performance than the components of their triad alone. And then this is one other graphic that I think is a great demonstration. It really shows the effects of low energy availability on an athlete's health, but also on their performance. So I know as the dietitian, I can sit and talk with a child or a teenage athlete about their underfueling or their nutrition for their health for weeks on end, and their eyes just kind of glaze over. But if I start talking to them about its impact on their performance, they kind of start to perk up, they start to listen, we start to have a conversation, and they get engaged. And so I think this can be a great graphic that shows, hey, this is the impact on the health, but this is everything that is going on with your performance. Like if we can optimize your energy availability and get you more fueled, you could see improvements in all of these factors related to your performance.
So I just wanted to briefly touch upon cardiovascular health and some implications that it can have on a female athlete or a male athlete as well too. So the study looked at female ballet dancers, and it has been shown that menstrual dysfunction can be correlated with endothelial dysfunction. And so endothelial cells are the cells that line our blood vessels. And so it showed that oligomenorrheic and amenorrheic endurance athletes showed impaired flow-mediated dilation. And so that's measured via the brachial artery flow-mediated dilation, which correlates with the endothelial function. And what they found was that those athletes who had irregular menstrual cycles or weren't having any menstrual cycles at all compared to those athletes who had normal cycles, the amenorrheic athletes showed the greatest impairment in their endothelial function. And so they looked at some professional dancers with menstrual dysfunction, and it also showed it correlated with low flow mediated dilation. And so while these studies were not exclusive to adolescents, it did include this population. And so it certainly raises concern that an athlete with the triad may be at risk of developing coronary artery disease, right? So looking at what are the health consequences we just spoke about, right? So low energy availability crisis adversely affects an athlete's bone health, reproductive system. It can negatively affect their cardiovascular health, their performance like Taylor just spoke about, and also their injury recovery. A lot of times athletes will say, it's just taking me a lot long to recover from my injury, or I'm not recovering as quickly as I used to in the past. And so those are all kind of red flags also to look out for as well. So briefly on screening and prevention. So that's the most important thing. Early intervention and help for these athletes before it goes into full blossom athlete triad is going to be key to prevention. And so Screening is best done usually at the pediatrician's yearly well visit, also with their pre-participation physical examinations that athletes have to do on an annual basis, or if you see a kid that just is coming for reoccurrent injuries, bone stress injuries, illnesses, just injury after injury after injury, and you're like, gee, what's going on with this kid? Those may be some red flags for you to look out for as well too. Again, for diagnosis, you only need one of the 3 triad components, and if an athlete has one triad component, and based on your good history, thorough physical examination, and your clinical judgment, you may want to evaluate for the presence of other components of the triad as well too. And so these are some of the Triad Coalition screening questionnaires that I screened some of my female and male athletes that were concerned about. The ones highlighted in red are also asked in the pre-participation physical examination handout as well too. Some important questions to screen for, right? So especially in our female athletes, if you're concerned about athlete triad or relative energy deficiency in sport, history of menstrual irregularities, history of stress fractures or stress injuries, family history of osteoporosis. A lot of times these athletes are perfectionists, so they're kind of type A, they're very OCD, they get really high grades, they're high achieving students and high achieving athletes, and so we typically see this in this type of personality athletes as well too. Or if they're getting, external stressors, whether it be from the parent or the coaches or teammate about their body image or their body weight, those are also important red flags to look out for as well too. And so the diagnosis is made with a thorough physical examination. It takes a multidisciplinary team, and also the athlete needs to be honest and willing. So honest and willing about their food intake, their energy expenditure, and so it really takes a village to take care of these kids. I'm fortunate to work closely with Taylor. We also have our psychologist. We have our physical therapists. We have our athletic trainers. We work with the coaches and the parents, and so it's a really big team effort that goes into this. So how do we approach these at-risk athletes? So the main thing is to listen to them. So instead of saying, oh, I think you've got the female athlete triad, you want to kind of introduce your concern and saying, I've noticed that you've had several stress fractures lately, and sometimes these injuries can occur if your bone isn't healthy or if your body is not getting enough energy to meet the demands of the sport. And so if you kind of introduce it in a very benign way, but showing your concern also, then that's where athletes will start to listen. You want to also educate, right? So fueling and performance versus numbers. And so Taylor went over some numbers, less than 30 kcals per kilogram of fat-free mass. You start to worry about underfueling. Those numbers are just going to breeze over the athlete's head. And so while we are educated about those numbers and things like that, from an athlete standpoint, you want to talk to them more about fueling for performance, fueling to optimize recovery, fueling to decrease energy risk. And so it's really important to come from an athlete's perspective as well too. And then, of course, red flags that we want to look out for, skipping meals or snacks. A lot of times these are unintentional. So the athletes are just too busy. They're running from class to class, practice to scrimmages to games. They're traveling. And so a lot of times they're unintentionally skipping these meals, but at the same time they're underfueling and having a negative effect on their body. But it can also be intentional too, as we saw with our patients Jane and Jacob in our case study. So it's really important. Social media, unfortunately, oftentimes has a huge influence of current, diet fads and trends and things like that. So really things to be on the lookout for. And so this is just a good resource that the International Olympic Committee consensus statement has put out about the relative energy deficiency in sport, and some things for us as educators and clinicians to look out for.
So I'm going to touch briefly on how we can help and prevent this from a fueling and nutrition standpoint. I'm not going to go into tons of detail on this, but I'm kind of going to give you the overview. So first and foremost, if you're trying to figure out where do we start in prevention, we want to promote fueling. I think this is a great graphic, a great pyramid showing before anything else, we just want to get the athlete comfortable with eating enough and eating throughout the day. So are they eating 3 meals a day? Are they eating their snacks? Or are they coming to school without any breakfast and they don't eat till 2 p.m.? We want to make sure that they're fueling throughout the day and getting enough energy, enough calories, and then we can start looking at what that consists of, macronutrients and the little micronutrients. We're also looking at optimizing, of course, bone health is a part of this, and I'm going to talk about a few of those nutrients on these next slides. So we want to look first, make sure that our athletes are getting enough calcium. As Dr. Chung said, these are prime bone building years, and so we want to make sure that our athletes are getting all the calcium that they need to support that. And so our calcium needs are as high as they're ever going to be during these years. And so you as whether you're the PT or the AT or the coach or someone else that's supporting this athlete, you can kind of look and see if you're at a school, do you have a training table? Do you have a snack box in the office for your athletes for pre-practice snacks or any recovery snacks? Can you include foods that are high in calcium and help just call awareness to this? The second micronutrient is vitamin D. We look at this a lot in our athletes. We know the body needs that vitamin D so that the calcium can do its job. And really here, if you know that your athlete's been struggling with maybe a stress injury or a stress fracture, or you know that your athlete is taking a vitamin D supplement, kind of reminding them, hey, are you still taking it? Are you taking it regularly? And how are you taking it? Vitamin D needs fat to be absorbed. So are you taking it with a meal, or are you taking it with a snack that has some fat in there so that we can really optimize absorption and protect your bones and improve your health and performance? And then the third nutrient I always look at is iron. There's more research being done about iron and its impact on energy availability. We know that overall, though, it does help with performance and health in our athletes. And so this would just be if you know you have an athlete who doesn't love meat or other iron-containing foods, trying to just be mindful and have that conversation with your athlete about foods that contain iron and how they're getting this nutrition each day. When we're talking about, how do we have these conversations? How can we support our athletes? When we think they're underfueling, we're trying to help them optimize their intake to prevent the male or female athlete triad or red S. First of all, we want to remember that with any form of underfueling, intentional, unintentional, early intervention is key. So if you think your athlete is underfueling for any reason, it's important to go ahead and have that conversation with your athlete. If you feel like you need more support, then reach out to a sports medicine physician, a sports dietitian, a sports psychologist to see how we can further help and support the athlete. I always remind my families, those I work with, that the best nutrition plan is one that allows for and supports adherence. So every athlete is going to have unique needs, and we have to remember that we may have this picture of what we know they need. Like, this is what it should look like, but when we're starting out, we really have to take one thing that the athlete can do. What works with their schedule? What are they open to doing and changing? And start there. So it doesn't have to look perfect, but it needs to be something doable. And then athletes that are struggling with low energy availability often have to eat on a schedule. It's not always fun. The athlete may not be super hungry. It's not easy. So we just have to remember that and be encouraging and really supportive of them when they're trying to make these changes. Specifically, when we're looking at the female athlete who is trying to restore her menstrual cycles, maybe it's been gone for a long time. This can require a lot of food and a lot of calories and take a lot of commitment. And I say a lot of food, we may look at it and say, that's really not that much food. But to an athlete, a female athlete that has been underfueling significantly enough and for long enough where they've lost their menstrual cycles for more than 3 months, it can feel like a lot of food to that female athlete. So we just want to remember to support them and encourage and be compassionate and really help them as they make these changes and optimize their nutrition.
So to wrap it up, so why should we care about the triad and relative energy deficiency in sport? So we just spoke about all the significant health risks that come with it. The consequences are potentially irreversible, such as long-term low bone health. and it dictates the need for prevention, education, early diagnosis, and treatment. So these are some really good resources for coaches, educators, health providers. The Female and Male Athlete Triad Coalition. There's a really good consensus statement out by the American Academy of Pediatrics that was put out by the Council on Sports Medicine and Fitness. There is also a site for Female and Male Athlete Triad Coalition physicians. So thank you very much, and we'll take any questions.
Dr. Chung, Taylor, thank you guys very much. It's a great, great talk. First, I want to open up to anybody in the audience that had any questions, any specific questions out here anybody has? All right.
Hello. First off, thank you guys so much. One of the questions I had was, you talked about the unintentional reduced energy availability in our active athletes, and I feel like that's something that I've seen a lot of. Do you, and you touched on this, but do you typically recommend going at it in a like multifactorial where you try to attack both their activity and their diet, or do you recommend doing diet first? Because sometimes I feel like it's hard with our active athletes, especially gymnasts, who are practicing every day of the week for multiple hours to attack activity level. So do you start with their diet, nutrition, and then kind of work towards activity restrictions?
Yeah, so that's a really good question. Thanks, Cody. So yes, if we're seeing an athlete and they're underfueling, we don't start off by saying, oh, you need to cut your hours from 22 hours a week to 10 hours a week. So usually we evaluate and then we assess like how can we optimize and increase their energy intake. And so that's how we start off first. Now, obviously, if there is an athlete who is on the more severe aspect of the spectrum for either male or female athlete triad, where they have low bone mineral density, they have multiple stress fractures, they are amenorrheic or having other reproductive issues, then we do talk about, okay, we probably need to decrease your training volume, and this is what we can do. So for instance, Jane, who we showed as an example where we were really concerned about underlying eating disorder, but she didn't present with a blatant eating disorder, but she fell off her growth curve from the normal 50% to like the 10%. She was bradycardic. She had other red flags. We did talk about significantly modifying and decreasing her training volume and intensity while we work to try to optimize her nutrition. But for most of our athletes, they're healthy, they're doing well, but they are underfueling unintentionally. Then we work with, okay, we keep the level of training that you're at right now. What can we do to optimize and maximize that?
Yeah.
Perfect. Dr. Chung, hold on, one more question. Hold on.
Thank you. I just wanted to know, do we have y'all intervene when they come to you with the first instance of stress fracture, or is it not until they've had multiple stress reactions or kind of red flag things that there's more serious intervention, I guess is what I'm looking?
Yeah, so that's a really good question. Thank you. Usually if it's an athlete who's otherwise healthy coming for like a first-time stress fracture or stress reaction, we don't do a full workup. Obviously, if they're coming in and they're falling off their growth curve, or they've got a history of recurrent stress injuries, and that's when we start putting our hats on and saying, okay, what do we need to start looking at, what workup we need to do. But if it's an otherwise healthy athlete with like a first-time stress fracture, stress injury, as long as they heal how we expect it to, we don't necessarily go digging for anything. Yeah.
Dr. Chung, on one of the slides you had, somebody made a comment online requesting the slides you had for your screening questions. Is there somewhere that there's access that we can get to everybody with that?
Yes. So if you look up, it's the Female Athlete Triad Coalition Consensus Statement. It lists all those questionnaires, and those are the questionnaires that are recommended for screening for those athletes with female athlete triad. Mm-hmm.
Perfect. Along those same lines, question, this is kind of a growing topic, hot topic, right? And so in Texas, we have our pre-participation screenings. Do those questions come up on some kind of a screening initially? Is that something that's kind of standard at this point?
Yeah, so I put up here, so the questionnaires in red are the ones, so the questionnaires highlighted in red, those are the ones that actually come up in the pre-participation physical examination screening questionnaire now. And then, so the recommendations are, if your athlete says yes to any one of these questions highlighted, then you should go ahead and ask the rest of the screening questionnaires recommended by the Female Athlete Triad Coalition.
And there's more and more people doing these screenings, so when they get a positive response to that, what's the next recommendation? You keep asking the questions, and then what's the recommendation
Yeah,
after
so
that?
then they should start looking at, if it's a primary care provider that has a positive questionnaire, then they should start looking at the kids' growth trends, height, weight, BMI, asking further questions about their menstrual cycle, their sport activity level, and so, or if it's like coach or a, athletic trainer who's asking these questions, if they are concerned about it, then, to send them over to us, and we're happy to take a look at them.
Perfect. Any other questions? Well, we're going to go ahead and wrap up. Really appreciate you guys. That was a great talk. A lot of good information in there. You guys, please don't forget to get your CMEs and reach out with any questions that come up through online. We'll get them answered. Thank you.